So we decided, you know what, let's just build everything from scratch. Let's build the clinics. Let's build the lab. Let's build the pharmacy. Let's build our product and tech teams. Let's build everything. Let's control the physician's behavior.
Mhm.
Um, Everything has to be done in-house so that the entire journey is one and seamless, and there's no like parts kind of fixed together. And then let's change that in-clinic workflow. So when a patient comes into GluCare, we've reversed the entire scenario.
So hello, Ihsan, and welcome to Impulse. I feel like I say it all the time, at the beginning of every episode, but I'm really looking forward to our conversation today. When preparing this season of the show, I told myself, we needed to do one episode that focused on metabolic diseases, around which there's obviously a great momentum in biotech and health tech. We're recording this on the 14th of November, and I just saw before that this is World Diabetes Day, so it's aligned with. It's quite, a good coincidence, I would say. So there are many reasons, why I was excited to, talk about this topic with you. The first is that, ultimately, the impact that these conditions have on society is huge. So I think, if we take the example of diabetes, there are more than 800 million people who live with it. I think there's more than 2 million people annually who die from it. And, the prevalence is only increasing. So the situation is quite alarming. And, on the other end, we have new treatments that are now, getting a lot of traction, like the GLP-1s from the incretin hormones family, that are really, transformative from a medical perspective. I think our understanding of these conditions is also, increasing on the let's say a research level, and on the tech side, our arsenal is also expanding. We see the democratization of continuous glucose monitoring use. We see also a large array of wearables that enable us to measure like a wide variety of biomarkers and vitals with clinical grade precision. So I think there are like many reasons to be excited and hopeful about the space. And my hope for today is really to help our listeners realize the potential that we have today to address metabolic conditions, which also when combined with a holistic care approach and new care delivery models like the ones you're spearheading with metabolic and that we will talk about today, can have a really incredibly positive impact on society. But yeah, before we unpack all of this, Ihsan, I will invite you first to present yourself, and thanks for being with us today.
My pleasure, Matteo. So I'm Ihsan Almarzooqi. Background, education-wise, started off as an engineer, did chemical engineering, then pivoted towards life science, did a PhD in gene therapy out of UCL. Also did an MBA out of London Business School after that. Started my career off in a sovereign wealth fund for the government of Dubai, building essentially life sciences infrastructure, so labs that other businesses can go and occupy and start creating an ecosystem. Moved over to the sovereign wealth fund of the government of Abu Dhabi, and became deputy CEO of a kind of a large healthcare division of that sovereign wealth fund. Everything was greenfield. We built everything ground up, new concepts, Cleveland Clinic, Abu Dhabi, Imperial College London Diabetes Centers, labs in collaboration with LabCorp. So a lot of partnership model from different parts of the world, but all greenfield, all start from scratch, conceptualize the project manage to eventually sitting on the board. And then a few years ago, I decided to um, go the entrepreneurial route for a number of reasons. I also saw the failure of traditional care settings. So, once you open so many different types
Yeah.
of healthcare providers and looking at the outcomes, you realize that whilst they're nice buildings, they're nice new entities, that they serve better than the legacy, but the outcomes were not significantly different. So the idea came that, we need to have a new care model around one particular type of disease group, metabolic health, which we'll talk about. And that's where my entrepreneurial journey started, 2028. It's now 2025. So We've now expanded our care model from one facility to numerous facilities, both in the UAE and outside the UAE.
Really, really cool. I thought as well, maybe, I mean, I talked about diabetes in the introduction, but maybe you can give us, a sort of like understanding of, metabolic diseases, let's say in general, and, what are their, let's say, characteristics compared to, other chronic conditions so that we can, maybe anchor our conversation around the, high level understanding of what these conditions are.
Yeah, I mean, most people think when they think metabolic diseases, they think diabetes.
Yeah. Hmm.
It's one of those, and I'll give you some statistics to see how large the total addressable market here is for metabolic health. But it's very similar in all developed countries.
Hmm.
So we are an endocrine practice. So the majority of our physicians are endocrinologists, and those are the kind of physicians who manage diabetes. Not
Yeah.
to say that diabetes can't be managed by family medicine or GPs, but our model is usually endocrine led, and GP supports it. Um, Metabolic health or metabolic syndrome, we know the aspects of it. It's not just, a fasting blood glucose issue or an insulin resistant issue. It's also a waist circumference issue. It's a hyperlipidemia or cholesterol issue. It's a hypertension issue. It's a weight issue too. So, all of these characterize what is metabolic syndrome. And you need several of these five to characterize as a, let's say, dysfunctional metabolic syndrome. Now, in diabetes, they usually have, more than two or three at the same time. But there's also
Hmm.
pre-diabetes. There's also obesity.
Yeah.
And then there's other endocrine disorders or hormonal health, everything from thyroid care to, PCOS to HRT. All of those are programs with that endocrine base, you can do quite a lot. Now, we
Yeah.
started off with diabetes. In this region, in the Gulf region, 1 in 4 people have diabetes. So it's about 25% of the population, very high.
Yeah.
Actually, the most countries in the top 10 are in the Gulf. And that's a correlation with the GDP. The higher your GDP, you'll just see more
Mm.
type 2 diabetics. Um, about 20% of our population is also pre-diabetes. And then about 10 to 15% are obese that don't have prediabetes or diabetes. So when you look at the total addressable market, it's
Hmm.
almost 60%. And no healthcare problem could be as big as this.
Yeah.
Uh,
Yeah.
Nowhere in the world. And then if you add hormonal health, which is to do with lifestyle and also some insulin resistance, and you start going to 80%. So we thought, the best way to tackle one single problem, if we were to tackle that, is metabolic health. We did start in diabetes, but the tools we currently have in our new care model, which we'll talk about, is very similar to prediabetes and obesity and
Yeah. Yeah.
PCOS. It's almost this, it's the same physician, it's the endocrinologist. It's almost the same lab tests, or let's say add-ons to the core lab tests, same diagnostics, the same GLPs that we will talk about too. The same care pathways in terms of lifestyle modification. So we started off with diabetes and we called ourselves Glue Care initially. And as we started capturing more and more of the other segments, um, you know, we thought about a kind of a name change. It's we're no longer, because people would say, "Well, I'm not coming to Blue Care. I'm not diabetic, but I really want to
Yeah.
optimize my hormones, or I feel like I'm starting that insulin resistance journey, or I'm gaining too much weight and I don't understand why." And all of these to us is metabolic syndrome. So there is a shift towards our branding towards metabolic, although it's a very difficult name to protect because
Yeah.
it's a descriptive name.
Yeah.
We decided that we will brand towards metabolic. It'll be probably announced in the beginning of the year. GluCare will remain. It remains a program that is centered around the research that we do. So that's the idea. That's the idea. We want to tackle the biggest total addressable market. And of that, we can probably service a big chunk of it by focusing only on metabolic diseases.
Mhm. Understood. Yeah. So I mean, I didn't, I was not aware, of these numbers in the Gulf region. And going back to what you saw in your previous experience, building up, labs and care providers. I mean, there's obviously like the need to absorb that amount of care that is needed to address that, these conditions at that scale. That's quite striking. Why? I mean, going back to that topic, like why or what were the problems you saw, in, let's say, traditional care models and approaches that failed, in approaching, let's say, rightly, this particular type of chronic conditions?
Yeah, look, let's look at it from a couple of ways. Let's look at what the traditional care models currently produce in terms of outcomes. We are
Mhm.
all using the same medications, and we're all using the same education in terms of managing a patient. So our pathways from managing a disease hasn't really changed. So, you know, if we look at the metric HbA1c, which is the average hemoglobin over
Mhm.
3 months, this is a typical biomarker, let's say, that most physicians use to describe. It's not the only one, it's not the best one, but it's the one that is currently the most common. In the UAE, despite it being a very, access to care here is not an issue. It's not the
Yeah.
NHS. You can get access to very good care. Everyone has insurance, nationals or expatriates. Um, and we have all the medications that were usually second or third globally to get these medications after the US or some of the European countries. Um, the average A1C here for a managed patient with diabetes is about 7.7. So everything above 7 is uncontrolled.
Mhm.
We asked, well, we have all of this access, but they're all hovering around 7.7, 7.8, which is disastrous
Mhm.
because it adds multiple fold in the cost of managing this patient. This patient will get other comorbidities, and then, the cost starts cascading upwards. So we have to ask, like, why is it 7.7, 7.8? It doesn't make sense. And this is a
Mhm.
patient who's regularly going to a doctor, taking all the latest medications, getting CGMs, and it hovers around that. And when I first set up the initial diabetes centers in my last career, I saw that number too. They're not getting necessarily worse with time because now they're better managed, but they're not getting better with age. So
Mhm.
as they grow older, it's only going to go one way. And we've never heard of a story of a diabetic who became older and better. It doesn't happen here. And the reason why is twofold. One is we are practicing medicine today episodically. We see a doctor for 10 minutes, he takes a snapshot of some diagnostics, some scans, creates a plan. That plan, which is problem number two, is primarily based on therapeutics, on prescriptions. There is
Mhm.
advice around nutrition, there is advice around lifestyle modification, but it goes from one year to the other. No one cares, no one tracks, no one does anything. The doctor is not incentivized to do anything beyond just prescribing. And then you come back in 3 months and do the same exact thing, where you get a snapshot, whether that the only real decision is, should I increase your medications or should I
Or
reduce
not,
them?
yeah. Mhm.
That's the only decision that happens. But in between these two visits, let's say from 0 to 3 months, the physician or the team is completely blind to what the patient is making in terms of a decision in his life or tracking. That's where the problems happen, not the
Mhm.
5 or 10 minutes in the clinic. Yet we don't have any visibility of what happens to this patient outside. So we said, okay, let's do two things. One thing, change it from episodic to being continuous. And two, let's change it from being only prescription medicine to prescription plus behavioral change, behavioral tracking. Now, that's easier said than done because the current care system or payer system today pays for what happens in the clinic.
Episodic,
It
yeah.
doesn't help. It doesn't actually pay you for changing behavior or tracking a patient or monitoring their step count or their stress levels outside the clinic. So no one does it. Everyone's focused on the in-clinic aspect. So we decided to create an end-to-end solution. And a lot of people in our initial journey said, well, you guys look like a remote patient monitoring platform. Why
Mhm.
don't you go to other clinics and give that software to them so they can do it? And I can tell you that if I did that, or if I took that advice, would have definitely failed. First of all, they're not incentivized to monitor patients, providers, because they're not getting paid.
Mhm.
Second of all, imagine going to a legacy provider today, a
Yeah,
traditional
yeah.
care provider. What does the in-clinic experience look like? And I'll kind of describe theirs and I'll describe ours. You go in, you see a physician, you describe your symptoms. I'm diabetic, I have diabetes for 5 years. I take these medications. I cannot do this. I smoke,
Mhm.
whatever. And they take notes and then they request labs. And in this part of the world, they ask for insurance approvals. Once the insurance approvals comes, then they go give the lab tests. And then, a few days later, they get a call from the doctor, your lab is this, that, you should change your medication, go to the pharmacy and pick up your medication. And then, yeah, you have a cardiac issue. You should probably go see the cardiologist and schedule an abdominal ultrasound at the same time. So the patient goes to different departments managing this care and come back in 3 months and we'll look at what happens. So today, this is a system dictated by what insurance decides they allow
To
that
cover.
physician to do and whether the physician is good enough to justify those tests. This is what it has today. It's completely controlled that way. The hospital, the clinic will never do a service which is currently not covered. They will not take that risk.
Yeah.
So imagine that was the status quo of glue care. And I added this additional remote patient monitoring or, continuous behavioral to this broken system.
Yeah.
You get no compliance of patients outside because that system is so frustrating to patient. This bouncing around from different departments, seeking, what do I do? What do I get insurance approvals? No, insurance denied this test, but I have to pay out of pocket for that test. That is a broken system. So adding a digital solution onto a broken system, you'll end up getting a broken digital system. That's it. So we decided, you know what? Let's just build everything from scratch. Let's build the clinics. Let's build the lab. Let's build the pharmacy. Let's build our product and tech teams. Let's build everything. Let's control the physician's behavior. Everything has to be done in-house so that the entire journey is one and seamless and there's no parts kind of fixed together. And then let's change that in-clinic workflow. So when a patient comes into glue care, we've reversed the entire scenario. They come in, let's say we know he has diabetes. He's told us he has diabetes on the phone before. So he goes in, we draw bloods. We turn those bloods in a huge panel in about 30 minutes. So we have created a real-time lab on site. And I'll tell you why we did that when I'm not sure why many other providers should be doing that because it's a huge convenience to their patient to get those labs immediately and have those discussions with the physician as opposed to a call, that happens 2 days later. Then we've added all the modalities we needed in a series approach, some of which are point-of-care AI software, FDA or CE marked, that allow the physician to get an immediate report without the need for a radiologist or an ophthalmologist to write a report, because that takes time. So I'll give you some examples. And I'll give you the real workflow of a diabetes. They come in, the first thing is blood so that, the clock starts on the 30-minute turnaround. But then they get a retinal scan, which gives us retinopathy and CVD risk. Both AI softwares don't need ophthalmologists or cardiologists. Then they do a pseudo scan. It's again another software that gives you neuropathy level. Then you do a liver scan. Then you do a thyroid scan and an abdominal scan. And an ECG and a body composition. Now, not all of these are obviously run with an AI software layer, but a lot of them are. So in this journey of 7 to 8 different diagnostics, takes about 30 minutes in total. By then, they go to a coffee shop, they break their fast, whatever, if they're fasting, and then they get called into the doctor. The entire results are ready at this point in time. So the labs are ready. All the diagnostics are written up. All of them are written up with the retinopathy saying you should see an ophthalmologist or not, so they can make a decision there. Everything is done. And the question is, well, did you get insurance approval for that? How did you run all of this without even asking the insurer? You didn't even see a doctor. And I say, well, you know what? In the end of the day, it's just maths calculation. I know what my rejection rates are with insurance companies, and I can calculate that. And there are certain things they'll pay for, and there are certain things they won't pay for. But I want the completion of the data set. I do a cognitive function test for every diabetes patient. Patients, the insurance companies never pay for that. The guidelines say it should be done. I do it because I want the data. Okay, so I know that I won't get paid for that. Whatever, I'll take that chance. Some lab tests are a little bit more difficult to get, but I don't want to have missing data sets for that. So I give the physician everything he can possibly need. So then they go into the physician room, and the first thing, they're surprised how quick all of this was. And then everything is ready. This is amazing. I've usually takes 3 or 4 visits and insurance fights and all that kind of stuff. They go into the physician room, and the physician goes into a presentation mode with the patient. So this is the first time we tell physicians, you need to present these results to your patients because I need the education process to start now.
Mhm.
You will be surprised how many patients who have diabetes or prediabetes or PCOS, they don't know what HbA1c is.
Yeah.
No one's ever explained it to them properly. Other than the other 10, parameters or 20 parameters that needs to be explaining, they don't even know the basics. Some even don't know what type of diabetes they have
Mhm.
because doctors have never given the time to explain it.
To explain,
We-
yeah.
We've created this wonderful dashboard, this, wonderful setting where the doctor goes into PowerPoint presentation. Well, it's not a PowerPoint now, but it looks like that. And the patient's just asking, what does this mean? What does that mean? Oh, it's high, it's low. Look at my scan. And we show them the scan. We want that whole process of agency to happen
Yeah.
with the patient.
Mm.
I want to know what the scan, even though I don't understand anything and what it looks like, I'm involved in the description of what I have. And that gives me some agency.
Yeah.
So they have this 45-minute conversation, and they're shocked because there was no insurance involved. And then we'll say, okay, here's your plan. We know exactly what your plan is. Then they go to, and they've been handed over to another team. The team downloads an app, gives them a wearable ring device, in our case, Aura,
All right. Mhm.
a CGM, a wireless weight scale. We teach them how to food log. And then we say, okay, you know what? There will be a minimum number of engagements from now when you leave the clinic to 3 months later when you show up again. And that's on us. And it's mixed. It's personal trainer, it's life coach, it's dietitian, it's diabetes educator, and it could be the same physician again if they need any discussions.
Yeah.
And they all have a chat without the patient, and they also have a chat with the
With the
patient
patient.
in the system. Now that kind of is the secret sauce. You have to have a minimal number of engagement. This is not rocket science. When they leave to when they come back, there needs to be a minimal number of engagement. To us, we publish these results. It's about 11 minimum. Okay, any less than 11, you don't get the effect of behavioral change.
Okay.
Any
Mhm.
more than 11, you can go up to 15, 16. Any more, you start getting the law of diminishing returns. You start to do too much, but you're going to get the same results. So you're just burning resources.
Yeah.
And that's the model. It's a continuous model. We call it the hybrid model. And patients absolutely love it. And the compliance out of clinic, that whole engagement that happens out of the clinic is high because the in-clinic experience was very good.
Mhm. I think, I mean, you touched on the, I wanted to ask you a bit the question later, but I think it's worth to ask it now regarding the, how is this, paid for, and how do you deal with insurances, and how do you, fund the whole system? Because I think, I mean, for people who discover this, through that conversation, they might be really surprised that we can
Yeah.
actually do this. And maybe there are some specificities to the, UAE health system or the Gulf region. But can you share a bit about how you went about this?
Sure. I mean, look, we knew insurance
Hmm.
companies do not know how to pay for behavioral change, wearables, tech, Aura rings. They're not going to do that. There's no codes. They don't exist. We
Yeah.
follow a very American system here, fee for
Okay.
service.
Hmm.
You provide the service, you get the fee, CPT code based. So unfortunately, all of what I described outside the clinic has no CPTs.
Hmm.
Okay. There are some exceptions to the rule. If you monitor a blood pressure cuff or CGM, you can get.
Yeah, yeah, for certain
Majority of
markers.
self-present, like if I put a personal trainer to change their exercise routine every week, we're not gonna get paid for that.
Hmm.
So there's two ways. You can either ask the insurance to pay for it, you can ask the patient to pay for it. If you ask the insurance to pay for it, they don't even know what you're talking about, and they're not smart enough to understand what you're saying. And there is no performance-based contracts here to kind of do a long-term
Yeah. Hmm.
performance-based thing here. So it's all fee for service. If you ask the patient to pay for it, they simply won't because everything else was covered by insurance. Why do I need to pay for this behavioral part? And people will start picking and choosing and say, no, thank you. I don't want the Aura ring. I'll just do the lab tests. And, insurance covers
Yeah.
four things here: labs, diagnostics, doctor visits, meds. That's it. Everything else, we pay for it. And, you might ask, well, how do you pay for it? Look, if I control the entire, and this is where I think a lot of digital health companies suffer. Today, digital health companies are struggling to get reimbursement because they are force fitting themselves into the
In the
legacy
system. Hmm.
payment model. Where do I get the money? Oh, the provider should pay for me. The patient should pay for me. You know, and it's not going to happen. You need to tap in to the payer. The payer will only pay what those four things. So if I control all four things, I have enough margin to cross-subsidize the things that doesn't get covered. So it's an internal call that we decided,
Mhm.
because our number one KPI or our number one mission is outcomes. It helps the outcome, so I'll do it. I've got margins in all other aspects of what I control in that bricks and mortars clinic that
Yeah.
allows me to do this. But if I was a digital health company, you know, either doing it myself or working with a provider, it's coming out of the provider's pocket and they just won't do it. And they don't
Mhm.
measure outcomes, so they don't care that all of these additional digital tools are helping their patient. They simply won't. They're for profit. So that's how we do it.
That's incredible. And I was thinking, so basically, I mean, the patient is really like no cost at all for the patients who benefit from it. And any
No,
patient can show up to your clinic, who have, I mean, I don't know if they need to have already, a diagnosis or be in a let's say, condition phase, like pre-diabetes, for example.
any patient can show up as long as they have coverage, which is the law here.
Yeah.
They should have coverage. Now, we are in network with most insurance companies. There are some, one or two, that we decide not to work with. And then there are some tiers that are in the lower category that the insurers themselves don't want those patients to come into
Hmm.
centers like
Hmm.
ours. But I wouldn't say that's everyone.
Yeah.
So,
Yeah. Mhm.
yeah, nobody needs to pay. Now, we will eventually move towards a different system because now we've proven the model works. And we do this for diabetics, pre-diabetics, and certain other metabolic health. So it's not for everyone who comes one time for a health checkup. They are not going to be put on the program because there's nothing to be put on that program. They don't need that behavioral change
Yeah.
aspect of it. So they have to qualify as per their clinical results. We are moving towards a membership model because, look, there are a lot of things we can do today
Hmm.
that have no CPTs but help the outcome of the patient. And I'll give you some very small examples that are currently not in the American Diabetes Association guidelines. You know, we can, for example, we do a risk assessment on kidney disease that is beyond the current urine test of ACR and EGFR.
Hmm.
There are new tests that can give us insights 5 years or 3 years before anything shows up in the urine. That today doesn't have a CPT. It's not covered by insurance, but
Hmm.
it would help me as to manage the patient better, bring the testing modality earlier. There's that new biomarker from Roche Diagnostics, the tau 217,
Yeah.
Alzheimer's screening 25 years before symptoms show up. And who gets most Alzheimer's than anybody else is people with diabetes. It's a strong correlation to insulin resistance. I want to run that, and I will. We're going to do it in January with Roche. We'll be the first center globally to do it as standard. It should be there, but if I wait for guidelines to show up, it'll take at least 5 years before it shows up on the guidelines. But this is the reality of what we're working with. We need to keep adding these modalities. There's a wonderful tool. With GLPs, the biggest problem with GLPs is muscle loss.
Hmm.
Muscle loss and as these GLPs get stronger and stronger with time and more weight loss happens, you get more muscle loss. Sarcopenia is going to be a massive issue. We found a wonderful solution that can give you a sarcopenia measurement without the need for a muscle biopsy, because no one's going to do a muscle
Yeah.
biopsy,
Yeah. Hmm.
obviously. And we're going to integrate that. Hopefully next month we will launch it. That again doesn't have a CPT. It's brand
Hmm.
new. It's new technology. I want to do it because it helps my outcomes, and this should
Outcomes.
be the
Yeah.
future. So we will eventually shift towards a membership model where you say, if you have insurance, we'll cover all the stuff that insurance does. But then there is a top-up membership where there's a growing body of clear evidence that you should be doing a lot more. VO2
Hmm.
test, wonderful tool that diabetics can benefit. The DKD, the tau 217. There's so many. We have so many of these new things. So that'll cover for everything else that the insurance won't. That's a model I think we will. It'll be like a hybrid insurance membership model. In markets outside the UAE, where we're not going to contract with insurance, like in the UK,
Yeah.
uh, we will go straight for a membership model, which is not common in healthcare, I understand.
Hmm.
But I think will be common if the cadence of patients continues to come as a preventative or participatory type of healthcare approach.
That's quite striking. I looked at, obviously at the website, at your website before, and I mean, there's a very clear focus on, outcomes, and almost like, everything you do it like almost in a research approach, where I think like you have very detailed numbers about all the markers you follow across all the population you manage. I mean, I assume one of the reasons why you do this is you want, to demonstrate the benefits, and you want, to some degree incentivize maybe payers and health systems to change how that broken model is operating. Is that what, like, your, let's say, long-term goal? I don't know if you can easily change that, right?
Yeah, look, research costs money. And
Hmm.
today, we don't make money from research. Most private healthcare providers don't do any kind of research. Unfortunately, even public healthcare providers do very little. We publish more papers here than almost all the private sector put together. And there's a reason for that. One is, remember when I said a lot of those things we do don't get covered for insurance? One
Hmm.
day I hope we move towards a value-based or performance-based contract as opposed to fee for service. So that'll definitely help when you have outcomes to show. You can, and we'll be in prime position to do that. The other approach, which many people don't think about, is our research is actually our marketing. Instead of telling people, look, we're the best in town, please come to us, like every other traditional provider. And if you ever come to Dubai, I'll
Hmm.
drive you down Sheikh Zayed Highway, and you'll see billboards of all the big legacy providers. We're the best, and we're affiliated with this clinic out of the US, and, come
Hmm.
to our new shiny center here. Zero outcomes. Nobody can tell me whether they actually produce good outcomes or not. So we've taken a completely different approach. Now, not everyone completely understands what we say, but this is part of the process of education of patients to say, look, go and demand with your physician. When you go to one of these hospitals that has advertised heavily in your marketing, ask them, what was the last A1C score for the last 100 patients? What are you trending today, dear endocrinologist? I can guarantee you that endocrinologists will just look with their eyes and say, I don't know what you're talking about. The other thing is that they will probably, if you go to the hospital and ask, they probably never measure any of that.
Hmm.
So taking that research as part of our marketing approach, and that's what we push out.
Really cool. I was also wondering, and you talked about the UK, where I think your next location will be open if it's not open yet. Um, how scalable is this model, beyond the country where you currently operate? And because I have the impression as well, it's always a bit the problem, with healthcare. It's very, local, like structures, and you might have archetypes that, are similar. Like you mentioned, UAE is quite similar to the US. I mean, I'm French, and it's quite similar to, like, for example, Germany. So how do you go about, selecting where you expand and considering whether, it's a scalable model beyond the local system where you operate?
Yeah, look, our decisions are based on a couple of factors. One, is there the need for this service? Is the
Yeah,
total addressable market large enough? And we know that most, let's say, nations have these metabolic health issues, so I'm not worried about finding those type of patients.
for sure.
Number
Mhm.
two, we look at the public system. Is the public system managing it? Is it doing a good job? Like in Switzerland, we know that they generally do a good job. Everyone will complain, of course, but relative to other countries, you don't have that much of a structural problem in terms of massive waiting lines, shortage of doctors. You don't have that.
Yeah,
So we have to think of that. And then we look at the private sector. Is the private sector offering something very similar? How does it look like? Does it look like an enhanced, public sector where you just skip the queue, or is there something more innovation happening in there? And unfortunately, in all the markets we look, there's a problem in all three. So the first market we decided to go, and we will have our first clinic in London, open in early summer. So, why London? People say, why didn't you just go to Saudi Arabia? It's next door. They have a big problem. They have the same issues. Look, London has a few unique aspects, or the UK has a few unique aspects. One is you have a metabolic health compromised population, just
population.
like everywhere else. You have an NHS which is not performing and is frustrating a lot of people and getting minimal care to patients who need it. Very minimal. I mean, a diabetes patient will see a GP and get most likely metformin with some other meds, see them twice a year max. No
Mm.
behavioral change support, no tracking, no endocrinologist involved. So, and it's resource constraint. So, that looks like a right market. Then you look at the private sector in London. It's whilst it's private, it's very traditional too. You go see a doctor, it's usually sole practitioners working as a collective group, renting out, a Hardy Street clinic. Um, that's not, I think, the future of healthcare. So our London
Hmm.
approach will be membership based. It will be priced per month. You will get unlimited care as long as we can do those care in the four walls of our building.
Yeah.
We've taken an 8,000 square foot facility in Knightsbridge. We started
Wow.
Knightsbridge because we actually needed to make sure the demographic is able to afford
Hmm.
initially
Hmm.
the first clinics. Obviously, we'll try to bring the price point down and expand once we prove it out the first model, but you try to de-risk the first one as much as possible. We
Yeah.
don't have insurance there. Insurance is not a big thing. So we don't
Hmm.
face the same issues here. There is private insurance, obviously, but they don't manage chronic disease. The private insurance is for acute. So we're excluding those guys too. Will that model work? I think so. I think there is a demand for that. I think we can prove it out. We're
Hmm.
also looking at the US. Actually, our second international site will be in Los Angeles. We're looking
Okay.
at sites
Hmm.
now. The US is a kind of mixed match between memberships and
And
insurance.
insurance. Yeah. Hmm.
And the market is massive there, and people are gone into this more wellness space there with these new brands that we hear a lot. But we're still staying very clinical focus, heavy on the clinical side, heavy on the diagnostic side. So yeah, we are expanding beyond the UAE. We're now at 4 sites by mid next year. We'll be at 4 sites, and our sites are usually, so that you can understand kind of how they look like. They're usually between 8 and 13,000 square feet. Those were the original
Yeah.
sites where you have everything under one roof. The future, because that's not also scalable too. Like we can't keep opening these large scale clinics.
Yeah. Yeah. Hmm.
It's slow. It's a slow process, and venture capital don't like that. But we're self funded, so we can stay focused on that. The next format of clinics will be much smaller. Will be 1,000 square foot onboarding clinics where you do all that diagnostic that I described earlier, and
Yeah.
then you leave, and then it'll be scheduled online because you don't need the lab real time. You don't need the pharmacy to be on
Hmm.
site. It can
Hmm.
all be
Hmm.
scheduled. They'll be in high density centers. So I think that's where we're headed. Both we'll try that first in Dubai and in the UAE, and then we'll look at the UK market if we can sustain that too.
Really cool. One question that came up when you were explaining in quite some detail the patient experience. And you said it yourself, when the first time they look at some of the results and it's the first time they have a proper presentation and education about their condition, which, empowers them to, take action. How do you make sure that this is not like overwhelming? Also assuming that, so you mentioned a few wearables. I mean, you give them an Oura ring, you give them a CGM, they have a scale. So, I mean, for maybe young people, I guess it's not really an issue, but maybe for, people with like more advanced in age, how do you make sure you don't, lose them? It's not like an overwhelming ask to, track all these things and staying, let's say, compliant to the programs you're delivering to them.
Yeah, numerous ways. One is you obviously need to give time to the doctor to explain it. You can't expect him to do all of this in
Five
5 10.
minutes, yeah.
So
Mhm.
we give them ample time to do that. Number two, you need to train the doctor to be able to
To
explain
do
it in the
that.
right way. Okay, because if you tell a physician today, hey, do you know how to read sleep data? They have absolutely no idea. No one's ever trained them in
Yeah.
medical school to do that. So we have actually a training academy. So any nurse, technician, physician, program manager, salesperson who joins us goes through several days of training of what exactly does every team member do, and then eventually they'll get the hang of it, and it becomes part of the clinical, record. Your sleep data is now part of the clinical record, as it should be. It's not today. I can tell you, it's separated in some cloud that Aura has, and then you have the
Yeah, yeah.
EMR, the medical record. We think that data should go all into the
Belongs, yeah. Mm.
medical record. And look, the presentation format needs to also be simple. We're creating these dashboards where you see a single person, which is your avatar, which we did from the body composition analysis because they have to do that spinning thing. And then you say, okay, let's click the kidney. I mean, it's an order, sequential order, but let's kick the kidney. Everything that you do in the clinic now related to kidney, whether it's a scan or a blood test, will first go through that. So, you compartmentalize it, you make it simple, UI, UX. And patients absolutely love it. Like they feel like this is like this is like a game. They've gone and they've seen their own
Yeah, yeah.
cars. It just engages them, and they say, "I've never been to anything like this." And none of this is rocket science. I keep telling all the other providers,
Mhm,
you can do
mhm,
it, but you need your own product team, and you need your own engineering team, and you need to think a little bit differently. Unfortunately, healthcare providers don't have a training academy for wearables. They
mhm,
don't have UI UX people on staff. They don't have a product team. They have to just license whatever is available and just work with that. So it's all kind of like patchwork stuff.
mhm, mhm,
I think the future of healthcare provider, if I'm a clinic or a hospital and I have some scale, I will have an in-house product and engineering team because I need to integrate wearables properly. I need to get the right kind of dashboard, not whatever is being supplied to me by the manufacturer. It doesn't work. So that is what I think will happen if you're trying to be innovative.
mhm. No, it's fascinating, like I think and I know if I ever go to, Dubai or one maybe London, to see the locations, with my own eyes, because I think it's quite I mean, I don't know if I would experience it as a patient, but just to see, how it operates, that would be super interesting. Um, you just touched on, your vision. I wanted to ask before we go to the recurring questions, because I'm mindful of the time. What do you think will be, let's say, or what are maybe your hopes and vision for how we will treat, metabolic conditions, maybe mid to long term, so like, in 10 to 15 years or 10 years onwards?
Um, Look, I hope, and we might be just one of many,
Hmm.
innovative care pathway providers, that people change the way we do things. Today, it's a replica of 30 years ago. The only thing that's changed is medication, some additional lab tests, and education access has changed, obviously. All of those have gotten better, but the way we currently manage a chronic disease is exactly the same. It's super episodic. So I'm hoping people do that. And when people say, well, how do you expect healthcare providers to change? Well, when you get a new device or a new therapeutic, you incorporate it
Yeah.
into your procurement list or into your clinic. Why don't you keep changing workflows? Like we change our workflows on average twice a month now, which is a lot.
Yeah.
Okay, and it is the start, but that's the only way to do it because there's a new thing that comes in. There's a new questionnaire that you have to incorporate. There's a new biomarker that's
Hmm.
recently been added. You have to constantly be on top of this thing. So you have to kind of think like that. You have to almost think like an engineer, not like a physician, in terms of optimizing workflows. When people say, "Well, we don't know how to do it. We're traditional healthcare." Look, we've published our entire protocol in the New
Yeah.
England Journal of Medicine, open. They can go and copy it if they want to. I know they won't because it takes a lot of effort. People say, you can't protect this stuff. You should let everybody. Okay, fine,
Yeah.
go and do it. But are you willing to sacrifice space to put a gym in your clinic? It's not going to make money, but it's going to help your outcome. Are you going to sacrifice some margins to build a research team that looks at your
Data.
retrospective data? I think because that's the only way you can improve if you know what your data is. If you're not measuring anything, what's the point of adding all of this stuff? And are you going to commit to changing those workflows to improve on last year's results? I mean, if you ask the typical CEO of a healthcare provider, he'll say, this is all cost to me. I'm not going to get paid for this. I don't know. My doctors will resist,
Hmm.
and there's a lot of things that's going on. It's just too much. I don't, I'm making enough money. I'm making a ton of money, actually, the way it currently is, which is if patients get sicker, they all make more money. There's more visits, there's more tests, there's more referrals. And this mindset needs to go in this fee for service model. It's not sustainable because eventually the provider and the payer, which already have a toxic relationship, they're going to start clashing. What I think will happen in the future, obviously, there will be a push towards performance based contracts as standard. We see it in Europe, we see it in the Netherlands. There's a lot of those happening. It works. It incentivizes the provider to think outside the box and say, okay, how do I get the outcome? Let me try different things. I think the collapse of wellness and healthcare will happen. For example, our next clinics, which the next one will open in a couple of weeks, it'll be our first clinic where we actually build gyms with tonals, those machines, those digital weight machines, in the gyms, in the clinics. Now, it's not a commercial gym, so you don't buy a membership to
Mhm,
go there,
mhm.
but it's an induction process where you don't get medication next month unless we see 5 sessions recorded on those, for certain people. Those who are
Yep.
losing too much muscle, we don't wanna give them the medication. So we have to be a bit strict in this, but we also have to give them access. We can't expect them to go get a gym membership just because we said it. So let's just
Yeah.
build everything around them. A future clinic will have a demo kitchen where they'll have to take a course on how to cook food. Like, you gotta start looking at this kind of collapse of wellness and healthcare. People talk about longevity and people talk about, you see it a lot, and it drives me a little bit crazy. But longevity isn't cold plunges and infrared sauna and NAD care.
Yeah. Mhm.
Longevity, if you want to tackle longevity, you can tackle 80% of longevity today by managing metabolic health more properly.
Mhm.
Whatever the tools that are needed in the toolkit for managing metabolic health, whether it's medications or exercise or diagnostics or nutrition or whatever, manage that. You've sorted 80% of the longevity question. The other optimizing factors are for a minority of people who don't actually need to come to the clinic.
Yeah, exactly, yeah. Mhm,
So I think that's what's going to happen.
mhm. No, I mean, it was really eye-opening for me. I think it's also like, I mean, it's the first time that I also hear, maybe from a more like philosophical approach, when you said, okay, well, we are including all these biomarker tests. We are also, you keep adding new ones that are relevant. You have a set of services that are not paid for, that are not paid for, and you're willing to, let's say, adjust um or take it into account actually in your business model so that you have the most holistic picture of the patient, and everything is done. You mentioned outcomes many times. I think we hear it also from the way you speak. I think that's what you're like pursuing. It's not like you are trying to optimize the system in a way that is both the most beneficial for patient but also like the most profitable. um, so yeah, I hope it will, I mean, to me, it was really an eye-opening conversation, and I hope it will, help a lot of people also understand that, this is actually possible. You said it's not rocket science. You're not, using some fantastic new, technologies that are, coming out of nowhere. So, no, thanks so much. Before we wrap up, I have like three, let's say, quick recurring questions I wanted to ask you, Ihsan. The first is, what resources you would recommend us to check out to know more about the field in which you work. I think you mentioned some publications. I mean, obviously, there's also a lot of details on your website. Are there any other resources you'd like to share with our listeners?
Yeah, I mean, I follow a couple of podcasts. A really good one is The Drive, Peter
Yeah,
Attia.
Peter Attia.
Very good, very up to date, very explanatory, and you can actually implement a lot of those things as a provider into the pathway. There's a good book called Super Agers, Eric Topol.
Yeah, I looked up. Oh, yeah.
Again, touches the longevity, but in a more clinical, realistic manner.
Yeah, yeah.
Not cold plunges, but actually, the use of medications across different disease groups that are not originally indicated. What are some of the new biomarkers that are coming out, but currently not in guidelines? A lot of that kind of stuff. So those two are usually very good. I think Eric might have a podcast too, or some affiliated.
Yeah, Ground Truth. Yeah, I
Yes,
think it
Ground
is.
Truth.
Yeah,
Yes.
newsletter. Mhm,
Yeah.
mhm.
So I think those are go to for me.
I'll put the links in the show notes. Can you share with us an additional or an anecdote from your work at Metabolic, that made you realize the impact that you were having on people's lives?
Yeah, I mean, look, when you're measuring outcomes, you can kind of see it collectively.
Hmm.
So if you're constantly measuring outcomes every 3 months, and send this to the insurance companies, I see, oh, okay, we've really improved these biomarkers, whether it's LDL or hypertension or A1C or time and range for these patients. So you see it as standard, but there's also some unique cases that
Hmm.
we've seen. We published a case study using remote cardiac monitoring of heart rate through Aura outside the clinic. So our cardiologist, ran a patient through a stress test and an echocardiograph, and so nothing abnormal or some abnormal signs, but couldn't get to the bottom of it. And she monitored this patient over the course of 7 days and saw irregular heartbeats at certain times. So, came in, did another few tests, but we essentially detected an abnormality in the heart that we would have never seen if we
Hmm.
just followed the in-clinic only approach.
Yeah.
I'm hoping biomarkers will be more So I think we get now good heart rate and HRV. Again, physicians don't know how to use HRV. This is another training module that one needs to do. We're seeing now, obviously, stress levels through the aura ring. Hopefully, we'll see blood pressure coming through too,
Yeah,
which
soon,
will
yeah.
help a lot. There's a new algo coming out for that. And there'll be more and more, and the glucose meters will obviously do multi-analyte measurements in the future. So, yeah, I think we see these wonderful single case studies, but we also see the scale studies. Both are important to differentiate yourself.
Very cool. If you would recommend, fellow healthcare innovator as a potential guest for the show, who would that be, and why would you recommend her or him?
I mean, we know quite a few in this space. Have you spoken to Professor Shafi? Shafi,
No, no, Professor Shafi Ahmed. No, I've seen him on conferences, but
yeah,
I haven't had the chance to talk to
you
him on
should
the
probably
show.
speak to him.
Yeah.
Great guy. He's a surgeon, obviously a
Mhm.
colorectal surgeon. He used a lot of the early tech to distribute or to televise his surgeries, kind of to do it for other surgeons who don't have that technical skills. So definitely, I can do an introduction to him if you've spoken to him. Have you spoken to Ali Parsa?
I've spoken to Ripasa. The episode hasn't come out, and I think it's the episode just before. No, two episodes before yours will be published. Yeah,
Yeah,
so we
I mean,
talked
look,
with.
Ali is an interesting character because obviously he has a huge success and there was a failure
Yeah,
in this. So he's got one of each, and his story is also important to learn what happened with Babylon. It is purely digital, so we don't
yeah,
really
it's a bit
associate
different.
as kind of a clinical provider, but it is a good lesson for all those who have gone into that digital health space. It is not
Yeah,
an easy thing to do. A
space.
successful
No,
digital
no.
health company is a few and far between.
Hmm.
Uh, so yeah, I would recommend those two guys.
Pretty cool. No, and if you can make an introduction to Professor Shafi Ahmed, that would be wonderful. I'd love to talk to him.
I'll
Isan,
do that.
thank you so much. That was really, an incredible conversation. So thank you for your time, and I wish you all the best with everything you have ahead of you, and also the new location in London. And yeah, I'll follow closely what the adventure brings to you.
Appreciate it. Thank you, Matteo. And yeah, anytime you're in Dubai, pass by. We'll take your blood.
Thank you so much.
Thank you. Take care.
Thanks for watching the episode. I hope you enjoyed it. You can subscribe by clicking on the podcast channel at the top right and watch another episode here at the bottom.